All right, we're going to go right to the Q&A. So we've got 1, 2, 3, 4. Okay, and then we'll see if we get some more in here. True.
I have two questions. The first one is this morning there was a reference to evaluating the immune system. How exactly is that done?
I can comment and then hand the mic over. So there's different ways to evaluate the immune system, and we can actually do this in some ways through just conventional laboratory tests, labs that we would get typically on routine patient visits. So one of the things that we track as myeloma physicians is something called the immunoglobulin levels. And so oftentimes in myeloma patients, something called the IgG level, which is basically a measure of antibody levels in your blood, are lower from the myeloma itself, and also from the treatments that target both bad plasma cells, which are the myeloma cells, and also good plasma cells. So sometimes you don't differentiate the two types of cells. And so that's one way that if it's low, we might recommend something called IVIG to essentially boost up your immune system to supplement the normal antibody levels to fight off infections. And there's more sophisticated ways to assess the immune system, which Bill does in his lab. Essentially, many differences too, but flow cytometry is one way. Since you're looking at different markers on the cells, on the immune cells, to basically that differentiate, identify what types of subsets of immune cells are low or high. Sometimes they're cells that act in a more inhibitory manner, or regulatory cells. Sometimes there are cells that help stimulate the immune system. So they're really all different types of cells and different sort of techniques and tools that one can do.
So Hans, you talked about functional high risk. It just as a concept, which is laboratory tests can tell us a lot, but the only way to really know how the disease is going to behave is to watch and see how it behaves. So there's something a little bit analogous to that with the immune system, which is measuring immunoglobulin levels, which often drop in myeloma because we're giving treatments that are directly interacting with the cells in the body that make those. They can give us a sense of how the immune system is doing, but they don't. But we can't totally rely on that. The thing that really tells us how it's doing is the person getting sick a lot or not. And really, I've had patients with very low levels who seem to be very healthy and do fine, and we generally don't have to do anything about the immune system. And others who have pretty good immune globulin levels, but who just seem to be always sick. And those patients, there are treatments that we can give to kind of bolster the immune system.
Thank you. I certainly agree with all of that. I think, it's very common for myeloma patients to come in, and often, some of you may have experienced this personally, is that myeloma patients are sometimes found because they go to their doctor and say, "Doc, I'm always sick all the time, right? I'm having infections. I've got a sinus infection. It's the sixth time in the last few months." And if you have a suspicious and paranoid PCP like mine is, which is great, then they go looking and they can occasionally find these things. But, and then there are different arms of the immune system, and they all may be impaired in a slightly different fashion. So I have these patients, as you're saying, who walk around with immunoglobulin levels that are like ridiculously low, but nothing happens. And there are others who have immunoglobulin levels that are higher. And so how each of those works functionally is a bit different. I do see patients who have, let's say, MGUS or smoldering myeloma, who, if I see over time that immunoglobulins, which used to be higher, are slowly meandering their way down. And I feel like over time that reflects to me a dynamic state where the immune system is slowly becoming more suppressed. And I feel like that's one way for me to anticipate what might happen in the future. That seems more like more biological activity to me. So these are some of the things that the myeloma physicians look out for. I think I would agree very much. I think behavior trumps everything else. We all have patients that come into clinic with the first time a disease that appears to be ultra aggressive, 10 years later, they're still pottering around, doing well, going to Colorado skiing. And then there are people who come in with what looks very much like standard risk disease. And the first thing that you notice is that after 4 cycles of excellent treatment, the numbers haven't come down by more than 50%. And primary refractory disease, in my mind, is a challenging entity. And early relapse after transplant, as Hamza said, as Mattis said, as Bill said, these are all challenging entities. So an immune system all has a part to play in all of this. And a lot of it is suppression from myeloma as well.
Oh, okay. Yes, the second question is, earlier today, MGUS was referred to as precancerous. What exactly is smoldering? Is it precancerous, cancerous, or something in between? I don't know, like, when people ask me, I say, oh, I think it's cancer, but I'm not sure. So anyway.
Yeah, I
that's my
think it's,
question.
it's trying to sort of put a label on something. I think that it's, here again, it's sort of, if it's there, but it's not hurting you, then we would be more apt to say it's precancerous, right? I think that if it's there, you're starting to get anemic, things like that, then we'll say you cross the line. It's, there's no set definition. There are definitions in like solid tumors, like melanoma, colon cancer, where you can look at the tumor and sort of say whether it's precancerous. In myeloma, it's so difficult to do that. And so I think here again, just looking at the plasma cells is not going to tell us anything. It's really how is it affecting the patient? And that really, I think, defines more what we would call
I think there's a lot of heterogeneity in smoldering myeloma patients, how their myeloma will behave in the future, and we just don't know. We don't have great tools. I guess maybe one way to think about it as well is we just think of the biology of, or how the cells are actually intrinsically wired. Probably in smoldering myeloma, half the patients have MGUS, half the patients actually have myeloma, and we just don't have good enough tools to differentiate and dissect which half has which and which half the other. So we kind of lump the patients into this kind of general category as smoldering myeloma.
So thank you. So for me, conceptually, it took a while to wrap my head around, as I'm sure it does for most people. And I tell patients who come to clinic that you don't need to remember any of this. There's no quiz at the end of it. But what MGUS really means, right? It's a long name. It means monoclonal gammopathy of undetermined significance. What does that really mean? I mean, there's no significance. It has no impact whatsoever, even in its current state. And initially, when these terms were coined by Dr. Bob Kyle at the Mayo Clinic, and he was in this discussion with this other famous hematologist, Dr. Waldenstrom, who was like, I want to call it a benign gammopathy. And Dr. Kyle was, no, it's not a benign gammopathy. What he was specifically saying is that the fate of this, how this is going to end up, remains to be seen. It may not have a huge significance now, although we're discovering more that even when people have MGUS, there is a predisposition to certain conditions. There's a slightly higher chance of getting another cancer in the future. It's a teensy-weensy risk, but it's there. There's a slightly higher tendency towards not having robust response to COVID vaccination, things of that sort. We're finding these things out over time. But essentially, the thing was that the fate of this remains to be seen. So now when patients ask me this very same question, look, is this cancer? What does it mean? I'm like, well, it's not cancer yet. And it may turn into cancer. It is a precancer, technically speaking, but even those definitions are a bit blurry. But conceptually, the thing to understand is, I'm happy it's not causing problems right now. We will keep an eye on this. We just need to bear in mind that it may go that way one day. And that's why vigilance within reason makes sense. Smoldering myeloma is just a bit further along than MGUS is.
Or if you could expand a little bit on one bullet point from Dr. Ali's presentation. She talked about maintenance therapy post stem cell transplant, MRD negative. I think your point was continuous Revlimid or maintenance therapy until progression or tolerance. Well, I've learned from my wife's experience, tolerance for me is, 1/10 or 1/100th of what she can tolerate. If you continue to be MRD negative, because if 3 years, 4 years, 5 years, at some point, it seems like you've got to reach that level of saying, okay, the risk of further Revlimid, even, you're always going to have side effects and it always impacts quality of life. So what factors do you use to say, okay, at some point where you're doing well, you're MRD negative, we're just going to let you go?
This is it sounds like a simple, straightforward question, but it's an extremely challenging question. It's very, very interesting. So the question of maintenance post-auto transplant. So here goes. There are still holdouts who feel that some very famous ones at Hackensack who will go unnamed, but who feel that long-term maintenance beyond 2 years is not, the data don't necessarily support it. There are people who were holdouts, some people at the Mayo who will not go named, but who came around when Phil McCarthy at Roswell Park published this meta-analysis that looked at 3 major studies at looking at Revlimid maintenance post-transplant. And the things that people were trying to determine from these studies, the CFGB study, the PEMA study, and the Gamma study, were 2 or 3 major things. One is that did it really help people stay in remission longer? 2 is that did it help people live longer? And 3 was that did it cause them, again, was the bang worth their buck? Did it cause them too much toxicity or not? And the gist of it all was that it did help people live longer, the longer you stayed on maintenance with Revlimid, that it kept the cancer away for longer, kept a lid on it for longer, helped you live longer, but that even though there may be a slightly higher chance of getting a secondary cancer, the benefits outweigh the risks. Now, there was one study out of those 3 that showed that there was an overall survival benefit, that you did get to live longer, which is also the study that showed that you had a little more higher risk of cancer. But there were a lot of people who were holdouts, famous holdouts, up until that meta-analysis came out, and they were like, you know what, this sort of makes sense. This kind of makes sense to us, that this is a good study, this is a good evaluation. So when you distill it all on a day-to-day basis, what do I tell people? I tell patients that, look, the preponderance of the data suggests that being on Revlimid maintenance is better for you than not being on it, and being on it longer is better for you than not being on it. And there are studies, prospective ones, retrospective ones, some of which have come out of our colleagues, our transplant colleagues and myeloma colleagues at MD Anderson and other institutions, which show that, look, the longer you're on Revlimid, the better off you are. Now, that's certainly not true of everyone all of the time. Who are those people? We don't quite know yet. Are they people with low risk disease? Are they people with certain genetic mutations? Are they people who are MRD negative? Or are they people who are MRD positive but have been knocked back into an MGUS-like state? When can I stop? Most of the times, I have a number of patients. When Bill left Hopkins, I inherited a patient or 2. And when Yvonne, who has moved out from Hopkins, has left, I inherited a patient or 2 from him and also from Caroline. But these are patients who they treated a decade or so ago and then have been off treatment since. Now, that's very, very interesting to me, because if those same guys were treated today, nobody would be left off treatment. Yet, what would we have done to all these people? We would have been subjecting them to treatment for years and years that these guys still needed. But I have no reliable way right now of identifying who that is, at least not in a reproducible fashion. So what do I tell patients? What would I tell your wife is that, look, first of all, we need to sit down and see, what are you actually experiencing on a day-to-day basis? What can we do to mitigate this? Right? Are there medications that might help you beat the side effect? Is reducing the dose going to help? Is spacing out the dose going to help? Are there simple measures that we can do? Then we really need to get a sense for, is this deal breaker is a strong word, but is this something that is impacting your quality of life to the point where you're like, look, it's simply not worth it? In which case it probably is. Then we should stop, rethink this whole thing, and decide what we're going to do. There was this meeting in Boston in 2019, just before the pandemic, of the International Myeloma Society. I remember this because there were 2 people. I forget who one of those guys. One of the gentlemen was from France, advocating. There was a debate with Dr. Vincent Rochemont actually sitting there with a whistle and a referee shirt. And he was moderating the debate. And he was one of those guys that used to be a holdouts, no maintenance beyond 2 years, who changed his mind later on. But there was a gentleman from France who was like, I'm going to argue for maintenance up to 2 years and not beyond. And I forget who the other gentleman was. It was like, I'm going to argue for maintenance indefinitely. And they did a poll before the debate started, and most people in the audience were like, yeah, maintenance indefinitely. And then these guys talked for about 10 minutes. At the end of it, what was surprising to me was that the gap had closed, because the gentleman from past made a good case for why we don't need to do maintenance beyond 2 years. I find that interesting. I'm not convinced enough to tell patients that they should absolutely stop unless there's a good reason. But if there's a good enough reason, then I think that makes sense, right? Nothing exists in a vacuum. And our patients' lives and their comfort are not separate from the process that's going on with them. I'm not treating a cancer, treating a patient. So these are all things that we need to sort of think about in factoring into it. So I don't know if you guys understand about me. People have thoughts about it.
I guess what I would say is that I am one of the folks who doesn't understand necessarily how we should use MRD, right? And I think that I don't do much MRD testing because I have found that you make the same decisions whether you have MRD data or not, right? Because there's no data. We're waiting. There's good trials. We'll have data soon. But when MRD doesn't, I would say, is the MRD reflective of the tumor or is it reflective of the doctor, right? So if it's reflective of the doctor, then the doctor is not giving you enough chemotherapy and you should get more chemotherapy if you're MRD positive, right? But let's say that tumors that are more aggressive, they're harder to get rid of, right? So maybe what MRD is telling us is not how much chemo you should get. Maybe it's just telling us how tough your cancer is, right? And so what we don't have is, we know in every study where you look, you take people who are MRD positive, MRD negative, people who are MRD negative do better always, right? What we don't have data on are, if you're MRD positive and we do something, is that actually help or not? Or if you're MRD negative and we do something differently than we would do, is that better or not? We do not have that data. We'll have that data soon. But at this point in time, like I said, I felt like MRD results were just anxiety provoking, and you get a lot of calls about them, and people wake up in the middle of the night asking about, what should I do with my MRD? And I'm like, I don't know, because there's no data to guide me. Okay. So in terms of MRD, I think that here again, it's something where maybe it makes sense, but if you think about the entirety of oncology and where MRD has been actually important, the really important places has been kids with leukemia. So you give them chemo, you do MRD testing. If they're MRD negative, you give them sort of a little more chemo. If they're MRD positive, you give them a lot more chemo, and then they survive. Okay, but there's not many other trials that tell us if you get this result and you do X or Y based upon that the outcome is better. We just don't have that data. We're waiting for it in myeloma. So in the MRD case, I would just say, I'm sorry, but I don't know. I don't know what to do with that information.
Can I ask you that? Oh, if you have a high risk patient, right? Let's say amplification of 1q or deletion 17p, and you give them 4 cycles of VRD or DARA-VRD, 4 to 6 cycles, and now they're PET negative, stringent complete remission by markers, and MRD negative, and they're like, so what about this transplant business? So are all MRD negative?
No, because so one good example is that, so let's say you're MRD negative after induction and a transplant. So what is your progression-free survival in that case? MRD negative. It hasn't been reached yet, right? We don't know. It's years and years and years and years. What if you're MRD negative after getting CAR T-cell therapy, after getting a Beckler? What is your PFS? It's about a year. So you're achieving the same level of MRD, but it's totally different because the patients are different and the treatments are different. So MRD is very, very, very contextual. When you do it, what the drugs are you use to get there, right? And so I think that just blanket saying we need to be MRD negative, it probably matters in some cases. It's probably not going to matter at all in other cases, right? It's all going to be the context of which we do it. So I think that's what we need to figure out, the nuances of it. But when people say, oh my God, you're not doing MRD testing, I'm like, why? Like, I don't know what to do with the information, right? And I don't want to be woken up 3 times in the middle of the night with someone saying, "Well, I'm MRD. I think I might be MRD positive." Right? Okay, congratulations. I don't want to say that. So there, what I would say is that if I have a high risk person, I think that person benefits from good induction, a transplant, and probably multi-drug maintenance. And I don't care what the MRD says. I would probably do that.
So when Rick got diagnosed, we were told that less than 2% of all the people in the world had multiple myeloma. And yet I knew 3 people who had it and hadn't survived, and now know a couple more besides Rick that have it. So is it just not being diagnosed properly? I know it's probably not as easy to diagnose. And then the other side of the question is, how do you think artificial intelligence is going to help or impair you? And I know that'll be a provocative question, but there it is.
Well, I think multiple myeloma is not one of the more common cancers. It's an uncommon disease, but it's more common than it used to be. And what I mean by that is the number of people living with it is growing year by year. It's growing because the population is aging, and it's a disease that just tends to occur in older people. But most importantly, the myeloma population is growing because people are living longer who have it. So every year there are more of them. Right? So the incidence is still fairly low, but the prevalence is increasing. And then, of course, if you live in a place where people have very good access to healthcare and get tested a lot, and if you move in circles where people are in the age range where it reaches its peak incidence, all those will kind of enrich your sample of people you may encounter who have it. And to top all of that off, we now live in a world where, if you look around for or seek to make connections with other people with whom you have something in common, those people just magically appear on your screen. The Google algorithms will do that without you even asking. They'll start showing you, giving you this sense that myeloma is everywhere you look, because if they know that that's something that's important to you, and they want to, make those connections, advertise drugs and all those things.
In terms of using artificial intelligence to screen for multiple myeloma, I think, as mentioned earlier in earlier discussions, I think the mass screening patients and every patient that comes to clinic is not the way to go. So that's not what we should do. On the other hand, let's just say that people get routine labs to their primary care doctor, and we're all in this position. We might miss something. We might miss an elevated total protein, which maybe the first cell heads up something like myeloma ongoing or a precursor to multiple myeloma. Maybe it's slight anemia. So there might be some algorithms that can be used. Hey, this patient might be a little bit higher risk for developing or having, a monoclonal gammopathy, and something that we should look into. So maybe in the future, such algorithms could be used just as sort of help, tip off physicians maybe look into this.
I think that AI, there are many different ways you can use artificial intelligence. Just like there's many different things you can do on an iPhone, right? So like there's a very good example where you can tell if people in the hospital are going to need to go to the ICU. There's some methods to predict that, right? And, but one of the factors is that, are they on oxygen or not? Because if you're on oxygen, you have a higher chance of getting worse and going, right? And, someone told me that. I was like, well, obviously if the person's on oxygen, they have a higher chance of going. So I think part of the issue with AI is what do you apply it to? So like AI is I think great for like, people have used it to get more people into an infusion center than will fit. They redo the machine does the scheduling, and you fit in twice as many people as if someone just sits there with the calendar book, right? So there are things like that I think will be great.
I think that in terms of like predicting what we do with patients, I think it's a little bit difficult because we don't even know what the data we need to like feed into the machine is, right? And so artificial intelligence, like Chat GPT, is this labor intensive thing because you have to stuff all this data into it for it to give you the answers out. And so we don't know what data to put into the machine that will give us the answers about how diseases are going to do, what their best drugs are, right? We are still in the best. At some point, I think we have enough data that we can start to utilize that, but I think we're just so far from that right now. Clinical trials definitely are impacted by, like, you can increase the number of patients to say, yes, I want to be on a clinical trial by using AI. That has been shown. And the biggest parameter in that is they were already on a clinical trial in the past. So, but I think that there are clinical trials, I think will be a really great place too, because you collect so much data.
We're going to squeeze 2 more questions in.
This morning, we saw slides about what you called cure clinical trials, and they were the quadruplets, I believe, one with the stem cell transplant, one without. So I was really happy to see the one of trying to avoid the stem cell transplant. So it was 12 cycles. And I actually know a couple of people in Dallas that are, I don't think it's that same clinical trial, but it's the same idea of using the quadruplet DRBD for I think 8 cycles, and then see if they're reaching MRD negative, and so see if they could avoid the stem cell transplant. So in my little myeloma journey, I was, advanced stage 3, had tumors, 8 lesions, M protein of 10, kappa lambda ratio of 1300. And so I did RVD. I did that for 5 months. Then it failed. I switched to Kyprolis, Dex, did that for 5 months. It started to not work. So then we added Venclexta or Venetoclax. I am translocation 14q32. I'm not translocation 1114. After 5 months, it worked. So I have been MRD negative since May of 2019. After about 2 years, I lowered the dose, cut it in half, and then in July, I went off of everything. So I've been off of everything since July. I'm still MRD negative. So my question is, what experience do you have with Venclexta? And, I guess I'm kind of biased. It works so well for me that I would love to see it, be offered to more patients. And I don't think it's clearly still not FDA approved. Where is it at in the clinical trials? Do you think we should push it, to get it approved? Just kind of what's your thoughts on Venclexta?
Thank you very much. You don't look like a lady with an M-spike of 10 and kappa lambda ratio of 1300. You look like you're in pretty good shape with that. So congratulations. I think that's great. That's very, very wonderfully uplifting. So, so there's what works for the individual and what's generalizable to the general public. These are 2 slightly separate things. All of these curves that we look at, these are statistical analysis. There may be outliers at either end. There are good data, very solid data, looking at Venetoclax that show that Venetoclax can work and improve progression-free survival. But as Bill says, there's still some caveats that need to be sorted out. I have a patient who has a IgM myeloma, which is somewhat rare. And he also has a biallelic deletion of 17p. Right, I think you may have taken care of it. So he has a biallelic deletion of 17p. He's had myeloma for many years now. Extremely avid, extremely fit and healthy. He is in the community with one of our colleagues. He is on Dara, Velcade, Venetoclax, Pomalyst, and dexamethasone. And that has kept everything under control for the last 18 months, almost 2 years now, right? Within what is an ultra-aggressive disease. So for me, practically, for each individual patient where there is a translocation level 14 and things are moving along, I am going to try and use whatever I can within reason. I do try and use Venetoclax. And some of those patients I'm trying to use Venetoclax earlier. But I realize that that's a very ad hoc way of doing it, right? It doesn't really for me to see if this is the right thing for me to do all of the time, you really have to see follow-up trials, follow-up randomized trials, better design studies, larger sample sizes. Because what's happening right now, how much of it is due to venetoclax and how much did we luck out with one individual or another, it's difficult for me to separate all of that. But the tools are limited, even though there are a lot of drugs, right? For some patients, it progressed to all of those drugs. So if I have access to venetoclax, I will use it. The larger question then becomes is that am I ready to go to the FDA and say, hey, this needs to come up for approval? I don't think the FDA is ready for that either. I think they'll ask for more data. I'm still surprised at some of the approvals that they did accept. And, these happen at, amongst other things, there are ODAC meetings, there are Oncology Drug Advisory Committee meetings, right? There are a lot of people that are represented there. When I look at drugs like selinexor, for instance, when it had its first initial approval as a single agent, I'm still a bit surprised by that, right? If I saw a drug that killed 9.8% of people, then I would be very hesitant about approving that with a 21% overall response rate. But that's not the whole story. And there are other people at the end of this. I think the more data that we have to take to the FDA to show that something actually works, right? And works in a generalizable fashion, I think the better off we are.
But yeah, Brian, I was going to say very succinctly, venetoclax is a drug that I do use frequently in translocation 11-14 myeloma or relapse refractory. I think there's other markers, like you mentioned, you don't have a translocation 11-14, so something called BCL2, if it's high, it can work in patients, or venetoclax can work in patients with BCL2 high, in the absence of T11-14. And there's an ongoing trial based on the Canova trial, venetoclax dex versus pomalidomide dex in translocation 11-14 myeloma patients. That's currently ongoing. The readout is pending. So if that's a positive trial, potentially that could lead to the FDA approval of venetoclax in that subset of patients.
This is we're a little over, so this is the very last question. Just to prove that we're all listening to Bill and his 100,000 stem cells, maybe a futuristic question. Any thinking or studies related to umbilical cord blood and the treatment of intrafamily myeloma?
So I think that the quick answer is no. I think that part of this is a whole different topic than I usually get slaughtered about. The other topic is about like using cord blood as an source of allogeneic cells for allogeneic bone marrow transplant, which is a different kind of transplant. And I have, Abbas and I both have experience doing this. I think that it works in some people. It doesn't work in everyone. And so I think it's here again, it's trying to figure out who it really works for. So I'm an allogeneic bone marrow transplanter. That's what we do for leukemia. That's what we do for myelodysplastic syndrome. So I believe in allotransplants. They just got to find a place in myeloma, but they can be cured. So maybe in some way they'll be useful.
Can I just make a quick comment on that? Just to echo what Bill said, allotransplant for myeloma can work, but myeloma is a disease entity that requires cells that are somewhat experienced and that are, patients who get allotransplant for myeloma, the ones that get a little bit of graft versus host disease where the cells attack the host a little bit, those guys tend to do better. And umbilical cord blood just hasn't. We used to do these transplants in Arkansas and in other locations as well. They just haven't been as successful for transplant in myeloma as more mature cells from other donors have been. So it's a bit challenging. I'm not sure if it's really going to show us anything in the future. Thank you.